October 18, 2023. So this is the MCQ of the day from Marrow, and it is a free questions. It is a free questions that I have recently got from the Marrow. So let's discuss from it. All right. So a patient presented with vertigo, tinnitus, and head tilt. He underwent myringoplasty for safe type of CSOM 6 months back. What is your diagnosis? The options were given: perilymphatic fistula, labyrinthitis, pageant disease, vestibular schwannoma. So I have already marked the right answer. That is perilymphatic fistula. So let's discuss why it is a perilymphatic fistula. In perilymphatic fistula, the presentation will be of vertigo, tinnitus, and head tilt following myringoplasty. Alright, so what is perilymphatic fistula? It is an abnormal connection between internal air and middle air, resulting in leakage of perilymph from the cochlea or vestibule. Okay, so there is a leakage of perilymph from the cochlea or vestibule. This is the most commonly occurs through the round or oval window. So the causes of perilymphatic fistula includes post-stapedectomy, ear surgery with dislocation of stapes, head trauma, inner ear injury due to forceful valsalva or battered trauma, raised intracranial pressure, and occasionally spontaneous or idiopathic. Clinically, intermittent vertigo, fluctuant sensorial neural hearing losses, tinnitus, and sense of fullness in the affected ear are present. The fistula test is positive, and the HRCT of temporal bone is highly sensitive for detecting the fistula. Sorry for that, detecting the fistula. A combination of CT and MRI can diagnose almost all cases. Audiometry and electrocochleography may be performed additionally. So I have just talked about the clinical features, and let's talk about the management of perilymphatic fistula. It is conservative or surgical. In conservative measures, it involves avoiding activities that increase the inner ear or intracranial pressures and using intratympanic steroids for acute decompressions. In other options, there were labyrinthitis, Page disease, and vestibular schwannoma, which I will discuss one by one. In labyrinthitis, the patient presents with unilateral vestibular symptoms like sudden onset, persistent vertigo with associated symptoms such as nausea, vomiting, sweating, and pallor. There should be no association with cochlear symptoms like hearing loss, tinnitus, neurological symptoms, or sign of brainstem lesion. And the Paget disease of bone usually present with hearing loss as a prominent features when the skull is involved. It is not associated with history of surgery, trauma, or vestibulocochlear symptoms. All right, and a vestibular schwannoma or acoustic neuroma, it originates from Schwann cells in the vestibular division of vestibulocochlear, that is eighth cranial nerve, within the internal auditory canal. The main symptoms are progressive unilateral hearing losses and tinnitus. Other cranial nerves 5, 9, 10, 11 may also be involved. Thank you very much.